Thank you very much, Mr. Chairman, ladies and gentlemen. Excuse me, I have modified the title of my presentation as shown here.
Okay, we'll allow that.
First, I talk about the ABO-incompatible liver transplantation. The Paris group demonstrated that high rate of graft failure, 5-year graft survival only 20%, and showed increased frequency of severe rejection crisis, arterial thrombosis, and biliary injury. Strong immunosuppression and plasmapheresis had little influence on poor outcome and were associated with greater incidence of sepsis. They concluded that the use of ABO-incompatible liver transplantation is justifiable only in emergency cases. The same poor outcome was reported in Japanese adult living donor liver transplantation with ABO-incompatible grafts in 1998. Patients aged over 80 years remained at considerable risk of early fatal outcome, and that new strategies to prevent antibody-mediated rejection were required. The matrices Pittsburgh showed a high rate of early graft failure and histologically widespread hemorrhagic necrosis with intra-organ thrombosis and also prominent arterial deposition of antibodies and complements. He called this phenomenon single-organ DIC. The first breakthrough to overcome the poor outcome in ABO-incompatible LDLT is the intraportal infusion therapy, which we developed in 1998. The main purpose of this therapy is control of local DIC arising in ABO-incompatible grafts. We chose the three agents shown here: steroid, prostaglandin E1, and gabexate mesylase. These are infused continuously for 3 weeks after transplant through an indwelling catheter placed in the portal vein during operation. The protocol of intraportal infusion therapy and the clinical course of 2 successful cases were reported in Transplantation 2002. The National Registry of the Japanese Study Group for ABO-incompatible transplantation demonstrated this method produces better outcome in a large number of cases. After starting the protocol, 5-year survival rate in adults improved significantly from 30% to over 60%. The second breakthrough was the use of risankizumab anti-CD20 monoclonal antibody in order to deplete B cells. CD20 is expressed in pre-B cells, immature and mature B cells. So risankizumab depletes these cells, but no plasma cells which produce antibody. It's speculated that B cell remodeling may introduce donor-specific B cell tolerance following B cell depletion. The first successful clinical application of risankizumab as preconditioning in ABO-incompatible kidney transplantation was reported from Japan in 2002. In liver transplantation, the first case with combined use of risankizumab, plasmapheresis, and splenectomy was proposed from the US in 2003. Also, several institutions in Japan, including our own, started to use risankizumab from 2004. Our current regimen of preoperative management is shown here. Basically, risankizumab is administered more than 2 weeks before transplant and just after transplant. Antiproliferative agents, steroids, and plasma exchangers started from 1 week before transplant to reduce the level of anti-donor blood group antibody. The postoperative protocol consists of intraportal infusion therapy, triple immunoprophylaxis, and plasma exchange when antibody titer is elevated. Immunosuppression is rapidly reduced, and portal infusion therapy is discontinued from 3rd or 4th weeks after transplant, because we consider the first 3 weeks may be the critical period for antibody-mediated rejection, and accommodation is established thereafter. The improvement of patient survival clearly depends on the application of portal infusion therapy and riskissimab, as shown here. In our experience, the 5-year survival rate in patients who underwent ABO-incompatible transplants was similar to that in the ABO-identical or compatible group. Future problems and prospects are shown here. Appropriate dose and timing of riskissimab administration should be elucidated. The necessity or indications of splenectomy and intraportal infusion are much discussed in the riskissimab area. Other strategies such as intravenous immunoglobulin have been proposed, which will be validated by further patient accumulation. The concept of accommodation or B-cell tolerance in ABO-incompatible transplantation has become well known, but the mechanism still remains unclear. The elucidation of its mechanism will be the key to further improvement of ABO-incompatible transplant. The next topic is donor-specific antibody positive liver transplantation. The cross-match positive graft is generally regarded as a contraindication for kidney transplantation. However, in liver transplantation, the impact of positive cross-match on graft survival is still controversial. Some papers show little or no impact on survival in both deceased donor or living donor liver transplantation. On the other hand, there are many reports suggesting negative impacts on survival after liver transplantation. One of the reasons why results differ among the papers may be due to the difference of method to detect anti-HLA antibodies. Lymphocyte cross-match test by complement-dependent cytotoxicity is a fundamental method, although it is poor in sensitivity. PRA is a screening test for anti-HLA antibodies routinely used in deceased donor organ transplantation. Flow cytometry has become a standard method of direct cross-match because of its high sensitivity. Currently, a single antigen bead assay using the Luminex analyzer has enabled the determination of target HLA and the amount of donor-specific antibody. Recently, the Kyoto group analyzed the risk of preoperative produced DSA in ABO identical or compatible LDLT. 21 recipients were positive for DSA or AHG CDC test. In 18 recipients, the amount of DSA was measured as the mean fluorescence intensity, MFI, by Luminex single bead assay. Hospital deaths occurred in 7 of 11 patients in the high MFI group, showing more than 10,000 of MFI value. They concluded the high HLA class 1 DSA had a significant negative effect on the clinical outcome of patients with preformed DSA. Already, respectively analyzed the preformed DSAs in liver transplantation from prospectively collected samples by single bead assay. They demonstrated that preformed class 2 DSAs with an MFI over 5,000 were associated with increased risk of early rejection token by the previous speakers. They also showed preformed class 1 and or 2 DSAs with a high MFI were independently correlated with the risk of death. Strategy for DSA positive liver transplantation is similar to ABO-incompatible liver transplantation. However, the indication of these treatments still remains unclear. The value of MFI might be the criteria of selection of patients who need desensitization. Recently, the prevalence, incidence, and risk factors for DSA in maintenance liver transplant patients were reported by the French group. 13 patients had at least one DSA, and DSAs were still present in 71% of these patients at the last follow-up. The incidence of a de novo DSA is 9%, and 23.8% of these patients have developed an AMR, whereas Only 1.3% of patients without DSAs experience in acute Rishkin episode. Furthermore, Kanai et al. Demonstrated that de novo DSA development after liver transplantation is an independent risk factor for patient death and graft loss. I present here a very interesting case who failed in unexpected graft loss due to humoral rejection immediately after liver LDLT in spite of negative cross-match and identical blood type. The patient was 47-year-old female, primary disease was PBC. Preoperative CDC tests were all negative, suggesting very low risk in terms of AMR. Post-operative clinical course was uneventful for 5 days after transplantation. On day 6 to 7, liver enzyme levels suddenly and markedly elevated. The patient underwent steroid pulse, plasmapheresis, isquizumab, and emergency exploratory laparotomy, which revealed no vascular complication. However, she died on day 12. Liver biopsy proved that the marked hemorrhage and massive centrilobular necrosis, neither obvious endothelialitis nor cholangitis was observed. Immunostaining for C4D was positive on the portal endothelium and the periportal interstitium. CDC crossmatch on postoperative day 8 turned to positive for T and B cells. These findings suggest that the pathogenesis of graft loss was closely related to AML, and de novo DSA might appear in early postoperative period. Once AML is developed, it responds poorly to conventional anti-rejection therapies. The treatment for AML, such as plasmapheresis, isquizumab, and IVIG, are based on accumulated experience for AML in kidney transplantation. Bortezomib is a proteasome inhibitor that depletes plasma cells. Bortezomib have recently been introduced to treat AML in kidney transplantation. Encouraging results lead to adoption of it in liver transplantation. Several cases of AML in liver transplantation successfully treated by bortezomib have been reported. Eculizumab is a humanized monoclonal antibody that inhibits complement protein C5. It has been used preliminarily within renal transplantation to treat atypical hemolytic uremic syndrome and accelerate AML refractory to other treatments. The application of these two agents has been limited in liver transplantation. Therefore, further investigation is needed. In conclusion, ABO-incompatible liver transplantation is feasible with the use of intraportal infusion therapy and isquizumab, even in adults with an acceptable survival rate. Recent advances in methods to detect DSA might provide precise criteria of preventive treatment for AML in liver transplantation. Thank you for your attention.